Greetings and good evening, beautiful people. Thank you so much for joining us this evening. Hope you're having a fantastic day and week. Welcome to our live weekly YouTube readings of the final report of the California Reparations Task Force right here on the CJEC YouTube channel. This is the only live reading of the California Reparations Task Force's final report on YouTube. The final report of the first in the nation California Reparations Task Force is one of, if not the most important government reports about the Black American community since the 1960s. Equally important is also the foundation for current and future reparations legislation in California. The report is nearly 1,100 pages long, and we're bringing every page of it to you, chapter by chapter, every week on Thursdays at 7 p.m. Pacific Standard Time, so that you are properly educated in your advocacy for reparations in California. Today's reading of the final report is presented to you as a community service with support from the Reparations Organizing and Mobilizing Team at the Coalition for a Just and Equitable California. CJEC is California's leading grassroots organization born for reparations and reparative justice for Black American freedmen living in California. For more information on CJEC and our work helping to enact the law that created the California Reparations Task Force, California's law requiring state agencies to collect data on descendants of U.S. slavery, the Act to End Current Slavery in California state prisons, the California Freedmen's Affairs Bill, and more, visit www.cjec-official.org. Before we go any further, right now, I need you to do three things. First, connect to our YouTube channel by liking this video, hitting the bell for reminders, and subscribing to our YouTube channel. Second, get connected to us on social media by following CJEC on Instagram, TikTok, Facebook, and Twitter at CJEC Official, OFFICIAL. Finally, get informed and get involved. To do that, visit www.cjec-official.org to sign up for current and accurate California reparations news and information on our Get Involved page, and support our work by volunteering and/or donating. To donate, just click the Donate tab on the homepage of our website. Special thanks to our amazing fiscal sponsor, the California Black Women's Health Project. You can learn more about our fiscal sponsor, the California Black Women's Health Project, at www.cabwhp.org. By way of introduction, my name is Friday Jones. I live in Los Angeles, and I'm from Brooklyn. And I'm a volunteer reparations advocate with CJEC's Reparations Organizing and Mobilizing Team. The agenda for today, Chapter 29 of the final report of the California Reparations Task Force, the title of the chapter we're reading tonight is Policies Addressing Mental and Physical Harm and Neglect. You can follow along in the reading, download tonight's chapter, or the full final report yourself by going to our website, www.cjec-official.org/reports. Okay, we're about ready to start in our reading, but before we do, I have some special thanks and announcements to make. First, as always, I'd like to thank our good friends at ETM Media Group on YouTube for their live readings of the first California Reparations Report. You can watch their readings of the first report on their channel at ETM Media Group on YouTube and on our website at www.cjec-official.org/videos. Second, for those of you who don't know, historic reparations legislation in California is here, and more is coming. SB 490 is California's first lineage-based reparations-related legislation to establish the California American Freedmen's Affairs Agency. The bill was introduced by State Senator Stephen Bradford and will move forward this year. To read the bill, visit, you guessed it, www.cjec-official.org/advocacy. Third, as mentioned, more historic reparations bills are coming. Over the next several months, more reparations bills will be written. During this 2024 legislative session, we'll see those bills introduced and start moving towards passage by majorities of both the California State Assembly and Senate. To pass reparations bills in 2024, we need 41 Assembly members and 21 senators to say yes. When those bills are passed, we need our governor to sign the bills. So to make reparations a reality in California, the math is 41 plus 21 plus 1. That's 41 Assembly members, 21 senators, and 1 governor. 41 plus 21 plus 1 equals reparations in California. Lastly, but not least, special thanks to CJEC's Reparations Organizing and Mobilizing team, specifically our volunteer final report readers. And without any further ado, Chapter 29 of the California Reparations Task Force's final report. Policy recommendations. This chapter details policy proposals to address harms set forth in Chapter 12, Mental and Physical Harm and Neglect. These are bullet points. Address health inequities among African Americans, Californians by funding the California Health, Equity, and Racial Justice Fund. Improve health insurance coverage. Evaluate the efficacy of healthcare laws, including recent enactments. Address anti-Black discrimination in healthcare. Mandate standardized data collection. Provide medical social workers healthcare advocates. Improve diversity among clinical trial participants. Remedy the higher rates of injury and death among African American mothers and infants. Fund community wellness centers in African American communities. You can see Chapter 20 for text on this recommendation. Fund research to study the mental health issues within California's African American youth population and address rising suicide rates among African American youth. See Chapter 20 for the text of this recommendation. Meet the health needs of African American elders. Remedy disparities in oral health care. Address disparities and discrimination associated with substance use recovery services. See Chapter 25 for the text on this recommendation. Fix racially biased algorithms and medical artificial intelligence in healthcare. Fund and expand the UC Prime Lead ABC program to be available at all UC medical campuses. We're turning the page to page 790. Continuing with bullet points. Create and fund equivalent to the UC Prime LEAD-ABC program for psychologists, licensed professional counselors, and licensed professional therapists. Permanently fund the California Medicine Scholars Program and create and fund equivalent pathway programs for students in CSU and UC systems. Review and prevent racially biased disciplinary practices by the Medical Board of California. Address food injustice. Increase green space access and recreation opportunities in African American communities. See Chapter 24 for the text of this recommendation. Test for and eliminate toxicity in descendant communities. See Chapter 24 for the text of this recommendation. Increase trees in redline and descendant communities. See Chapter 24 in the text for this recommendation. Develop climate resilient hubs in redline and descendant communities. See Chapter 24 for the text on this recommendation. Remove lead in drinking water. See Chapter 24 for the text in this recommendation. And the last bullet point, prevent highway expansion and mitigate transportation pollution. See Chapter 24 for the text of this recommendation. Address health inequities among African American Californians by funding the California Health Equity and Racial Justice Fund. As set forth in Chapter 12, mental and physical harm and neglect due to discrimination, disempowerment, and neglect of African American patients by healthcare institutions, African American communities have suffered major gaps in healthcare delivery. The impact can be seen in virtually every aspect of physical and mental health outcomes. African Americans have higher rates of morbidity and mortality than white Americans for almost all health outcomes in the United States, and an inequality that increases with age. This is connected to African Americans suffering from weathering or, quote, constant stress from chronic exposure to social and economic disadvantage, which leads to accelerated decline in physical health, end quote. Unequal health outcomes, quote, cannot be explained away by factors like age, income, or education level, end quote. Through implicit biases, the racism the healthcare system treats Black Californians differently. Numerous articles and studies have documented the necessity of remedying the poor health outcomes among African Americans through reparations. Social determinants of health, such as household income, neighborhood wealth, education, and health insurance, explain about half of racial health disparity in life expectancy. One report focused on social determinants of health observed that, quote, studies suggest that health behaviors such as smoking, diet, and exercise, and social and economic factors are the primary drivers for health outcomes, end quote. And thus, addressing social determinants of health is important, quote, for reducing health disparities that are often rooted in social and economic disadvantages, end quote. But social determinants of health can be improved. An American Public Health Association report has found that community-based organizations, quote, amplify community concerns and, in coordination with public health departments, contribute more effectively to policy solutions, end quote. The task force recommends authorization and ongoing funding of the proposed California Health Equity and Racial Fund within the California Department of Public Health's Office of Health Equity. The Office of Health Equity would administer an annual 115 million grant program with appropriate year-to-year increases to address health disparities, focusing on social determinants of health. Clinics and community-based organizations, CBOs, could apply for grants either separately or in collaboration. Applicants would be required to demonstrate how funding would be used to ameliorate existing or emerging health disparities and include metrics for success. Local health jurisdictions serve as trusted community partners to extend public health messages and interventions to underserved and difficult to reach communities. This recommendation incorporates a provision from Assembly Bill AB 1038 to authorize a California Health Equity and Racial Justice Fund Oversight and Accountability Committee to monitor the distribution, implementation, and impact of local and regional grants funded by the California Health Equity and Racial Justice Fund. We are now turning to page 791. Nearly 200 nonprofit advocacy and provider organizations have urged that funding be prioritized for California Health Equity and Racial Justice Fund, which also has the support of members of the California State Legislature. Health clinics, tribal organizations, and other community groups contend that funding in the form of state grants from the Health Equity and Racial Justice Fund will benefit the communities that need the help most. The task force agrees and urges that the fund be established and resourced with a specific focus and mandate to include addressing health disparities suffered by African Americans with special consideration for descendants. Improve health insurance coverage. The California Healthcare Foundation reports that although Black Californians have higher health insurance coverage rates than the state average, quote, structural barriers in the healthcare system prevents them from achieving the health they actively seek, end quote. Moreover, a disproportionately high percentage of African American Californians rely on Medi-Cal. Medi-Cal provided coverage for 28% of Black Californians in 2019, compared to 10% of white Californians. Adults enrolled in Medi-Cal were more than twice as likely to report difficulty finding a provider that accepted their insurance as compared to those with employer-based insurance or Medicare. And this was the case for both primary and specialty care. At least some experts have identified low reimbursement rates for providers who accept Medi-Cal as a racial justice issue. The task force recommends closing the health coverage gaps through the adoption of a comprehensive universal single-payer healthcare coverage and healthcare cost control system for the benefit of all African Americans in California, with special consideration for those who are descendants. For the many African Americans in California who remain on Medi-Cal, the task force also recommends increases to Medi-Cal reimbursement rates to achieve parity with reimbursement rates of private insurance. Next section. Evaluate the efficiency of healthcare laws, including recent enactments. As established in Chapter 12, mental and physical harm and neglect, healthcare systems and institutions have systematically discriminated against and provided substandard care to African Americans, resulting in grave health disparities. Over the 2021 and 2022 regular session of the California State Legislature, a variety of bills were introduced in an effort to improve access to health care. Some of the measures that were adopted included Senate Bill SB 838 to further the efforts of the California Health and Human Services Agency to create a California-branded label for generic drugs to increase patient access to affordable drugs and lower healthcare costs. SB 644, requiring the Employment Development Department to share information with Covered California for outreach to persons applying for or losing unemployment benefits to enroll them in Covered California or Medi-Cal. And SB 1019, requiring Medi-Cal plans to conduct annual outreach and education to members and primary care physicians regarding the plan's mental health benefits. Further, Governor Newsom's 2022 and 2023 budget included a notable increase in spending on health programs, many of which were aimed at remedying issues of cost. Among other aspects, the budget included trailer legislation to formally establish the Office of Healthcare Affordability within the Department of Healthcare Access and Information. However, despite persistent health inequity, there is currently no office within the California Health and Human Services Agency, the parent agency to the California Department of Healthcare Services, California Department of Public Health, and a number of other health-related agencies that is specifically tasked with evaluating whether recent efforts have improved health disparities among African Americans. To address entrenched health disparities, the task force recommends mandating that the California Department of Public Health's Office of Health Equity conduct an annual review of California healthcare laws and policies, evaluate their effect on reducing health disparities among African Americans, and publish its findings and recommendations to the California State Legislature. These recommendations should explicitly include how to design and implement consequences for healthcare providers who do not address and reduce identified treatment disparities. This measure would include funding on an annual basis to hire permanent staff dedicated to these efforts, based on the Office of Health Equity's assessment of the level of staffing needed. This proposal builds on Senate Concurrent Resolution number 17, which was chaptered on April 30th, 2021, and states that, quote, the legislature declares racism to be a public health crisis and will actively participate in the dismantling of racism. We are turning now to page 792, and we're on the topic, Address Anti-Black Discrimination in Healthcare. Racial disparities in Black health outcomes are a result of historical racial inequality, discriminatory health policy, and persistent racial discrimination across different aspects of life in the United States. African Americans receive fewer procedures and poorer quality medical care across almost every type of diagnostic and treatment intervention than do white Americans. As stated previously, African Americans have higher rates of morbidity and mortality than white Americans in almost all health outcomes, and this inequality only increases with age. Fortunately, evidence suggests that these trends in health harms arising out of implicit and explicit bias may be remedied through concerted effort. Relatedly, the Association of American Medical Colleges, the administrator of the Medical College Admission Test, the MCAT, has expressed interest in testing students on situations that involve implicit bias. To address discrimination against African Americans in healthcare, the task force recommends the legislature add the completion of an evidence based anti bias training and an assessment based on such training to the graduation requirements of all medical schools and any other medical care provider programs in California receiving state funding and not already covered, including mental health professional programs, psychologists, PhDs or PsyDs, master's level programs in psychology or therapy for counselors, clinicians, and therapists, and programs for clinical social work. Next section, mandate standardized data collection. Dr. Mary T. Bassett, the New York State Health Commissioner and professor of the practice of health and human rights at the Harvard T.H. Chan School of Public Health, writes that, quote, long-standing racist government policies from housing to healthcare, employment, to a flawed legal system that have systematically deprived Black Americans of equal rights, opportunities, wealth, and resources around account for the reason Black Americans have poorer health and lower life expectancy. In addition to acknowledging medicine and public health's role in perpetuating racism and participating in local, state, and national conversations around reparations, Dr. Bassett advocates for using health outcomes captured in public health data as a key measure of equality. She notes that, quote, successful reparations means eliminating racial health disparities, end quote, and that, quote, until racism no longer drives negative effects on the health and length of a Black person's life, equity remains theoretical, end quote. A number of experts in the field also recommend improved data collection in order to advance equity in healthcare and health outcomes. The task force recommends the creation of a statewide standards for data collection and reporting of demographic and social needs data in order to reduce health disparities and address social drivers and determinants of health. This proposal could build off of Senate Bill SB 1033, which would have required the California Department of Managed Healthcare to develop and adopt regulations establishing demographic data collection standards and require healthcare service plans and health insurers to assess, quote, the individual, cultural, linguistic, and health-related social needs of enrollees and insureds for the purpose of identifying and addressing health disparities, improving healthcare quality and outcomes, and addressing population health, end quote. Next section, provide medical, social workers / healthcare advocates. A study completed by the California Healthcare Foundation revealed that the majority of Black Californians devote, quote, a great deal / quite a bit of effort to their health, end quote, and agree on many suggestions to address racism in healthcare. Black Californians agree that one way to remedy racism in healthcare is to expand community-based resources. Specifically, 84% of respondents believe it is extremely important or very important to expand community-based education on how to navigate the healthcare system and advocate for high-quality care. And 77% of the respondents believe it is extremely important or very important to expand the number of Black community health advocates and or medical chaperones available to patients. The task force recommends the legislature provide funding to ensure that medical, social workers / healthcare advocates are available to serve as advocates, chaperones, and third-party observers when requested to address African Americans' concerns and experiences and biases and other disparate treatment in the delivery of medical care and mental and behavioral health services. We're now on page 793. These medical social workers and healthcare advocates would be required to undergo implicit bias training and demonstrate cultural congruence with the community to be served. They preferably would be situated within trusted community-based organizations, which may be achieved through a state-funded grant-making program. The next section, improve diversity among clinical trial participants. Among clinical trial participants in the United States, African American patients comprise only 5%, while white patients comprise the vast majority. Explanations for these statistics include historical exploitation and racism, atrocities such as the Tuskegee syphilis study, which used unethical research practices and caused unnecessary harm, deception, and biomedical exploitation of African Americans. Clyde Yancey, MD, Vice Dean for Diversity and Inclusion at Northwestern University Feinberg School of Medicine, has noted that not all humans are the same psychologically, and factors such as age, illness, and genetic ancestry may result in drugs being metabolized differently or responding to devices differently. When trial pharmaceutical companies and medical professionals do not know how various drugs will work in different populations, for example, albuterol, a drug used to treat asthma, was found to have decreased effectiveness on African American children. Dr. Yancey has stated that clinical trial study designs should be intentional from the very beginning about being inclusive, especially when members of a certain group might benefit from being studied due to a prevalence of a disease in their group. Dr. Yancey also noted that governments should issue requirements for recruitment targets and provide incentives such as rewarding those who succeed with more funds or grant opportunities. Researchers have begun to institute changes to remedy lack of inclusion and representation for clinical trials, such as bringing trial procedures closer to where participants live, diversifying the staff who recruit people for studies, and designing trials to directly target underrepresented groups. A primary barrier to participation is getting to the central site for, quote, assessments, administration of therapies, tests to monitor results, and medications to take home, end quote. These locations can involve several hours per trip and paying for transportation and food. To remove this barrier, some of the procedures can be carried out at medical offices and clinics in communities where African Americans live. Dr. Aaron D. Martinez, assistant professor in health policy and management at the University of Massachusetts Amherst, has noted that there are a lack of principal investigators for marginalized racial and ethnic groups, which may also be a factor in underrepresentation of African Americans in clinical trials. She has emphasized that representation on the side of scientists as much as on the side of research participants matters, as they bring, quote, different perspectives to the research informed by both their scientific training and their lived experiences, end quote. Another barrier to participation is not seeing African Americans among recruiters and the staff who are explaining the trial. The CARE Research Center, which runs trials and consults on increasing diversity in trials, advises researchers to diversify the staff working on the studies, especially those who interact most with possible participants. Other proposed solutions include aiming for a proportion of African American participation similar to their proportion in disease incidence cases, providing financial support for study participants to cover indirect expenses such as time off of work, childcare, and transportation, requiring funding agencies to include race and ethnicity for assigning priority scores, as a final score typically determines grant funding and will lead to researchers actively trying to recruit African Americans and targeting enrollment in a culturally sensitive manner. To remedy this issue, the task force recommends funding competitive grants for clinical trials to subsidize participants' indirect costs, such as time off from work, transportation, and childcare. Undertake and complete clinical trials in communities where African Americans live and hire staff demonstrating cultural congruence with the African American community to serve as recruiters and staff explaining clinical trials. We have turned the page and we are now at the top of page 794. The task force also recommends providing extra funding and other incentives for state-funded studies in which the principal investigators are African American. Next, subject, remedy the higher rates of injury and death among African American mothers and infants. As established in Chapter 12, mental and physical harm and neglect, one of the most harmful legacies of slavery is the disproportionate maternal and infant death of African American women and children today due to lack of access to adequate reproductive health care. African American women experience disproportionate racial discrimination in access to quality and prenatal care. Expecting and new African American mothers often find that their reports of painful symptoms are overlooked or minimized by medical practitioners. African American women disproportionately experience adverse birth outcomes and adverse maternal care. Researchers have found evidence that this may be influenced by the uniquely high level of racism-induced stress experienced by African American women. African American mothers in California are substantially more likely than white mothers to suffer severe health complications during their pregnancy, give birth prematurely, die in childbirth, and lose their babies. The pregnancy-related mortality ratio for Black women during 2014 to 2016 was 4 to 6 times greater than the mortality ratio for any other ethnic group. Over the past decade, Black babies died at almost 5 times the rate of white babies in San Francisco. Further, Black women in California disproportionately experience unfair treatment, harsh language, and rough handling during their hospital stay compared to white mothers. Further, according to a recent study at the University of Texas at San Antonio, quote, during and after pregnancy, Black women faced heightened odds of death that were almost double those of white women, along with a risk of dying specifically from pregnancy complications that was 2.8 times that of white women, but more than any other racial or ethnic group. Black women died as a result of homicide. They were 5 times more likely to be killed this way than white women. Another recent study published by the National Bureau of Economic Research found, quote, the richest Black mothers and their babies are twice as likely to die as the richest white mothers and their babies, end quote, suggesting that the racial gap in infant and maternal care is not just explained by differences in socioeconomic status, but rather that there is a structural problem. The study further found that babies born to the richest Black women, the top 10th of earners, tended to have more risk factors, including being born premature or underweight, than those born to the richest white mothers, and more than those born to the poorest white mothers. Quote, with the support of doulas, women have been less likely to have C-sections and more likely to have healthier babies. With regard to bias, as the University of California, San Francisco's California Preterm Birth Initiative has documented, quote, numerous studies have demonstrated that doulas can help reduce the impact of racism on pregnant women of color by helping to provide culturally appropriate, patient-centered care, end quote. Despite the research showing its benefits, doula care has been underutilized, often due to barriers like cost, coverage, and lack of information. Having identified several barriers and implementation challenges related to Medicaid coverage for doula care, the Preterm Birth Initiative, in partnership with the National Health Law Program, offered a number of recommendations to bring about successful coverage of doula care, including one, setting a common set of criteria for doula qualifications or credentialing for insurers to pay for doula services. Two, developing doula reimbursement rates based on the amount of one-on-one time spent with the patient. Three, streamlining and organizing payments for doula services. Four, pushing for doula services to be classified as preventative services. Five, increasing their flexibility to pay for doula services. And six, allowing doulas to obtain payment direct from Medicaid. Building on steps that state has taken to advance coverage for doula care, the task force recommends that California's Department of Healthcare Services, DHCS, provide additional support for doula services, which is covered benefit January 1, 2023, to include, we're now at the top of page 795. Requiring DHCS to develop multiple payment and billing options for doula care and to ensure specific payments and billing practices, including that any doula and community-based doula group be guaranteed payments within 30 days of submitting any claim for reimbursement, requiring DHCS to establish a centralized registry listing any doula who is available to take on new clients in each county, requiring each Medi-Cal managed care health plan in every county to provide information in its materials and specified notices on identified topics related to doula care, including reproductive and sexual health, and to inform pregnant and postpartum enrollees and prenatal and postpartum enrollees at appointments about doula care, such as the availability of doula care and how to obtain a doula, requiring DHCS to convene a doula advisory board that would be responsible for deciding on a list of core competencies required for doulas authorized by DHCS to be reimbursed under the Medi-Cal program, requiring doulas to provide documentation that they have met the core competencies specified by the board as a prerequisite to being reimbursed under the Medi-Cal program, requiring DHCS to work with outside entities such as foundations to make trainings that meet the core competencies available at no cost to people who are from communities experiencing the highest burden of birth disparities in the state, and providing funding of DHCS for data collection, reporting, and analysis to evaluate maternal health outcomes resulting from having doula care as a covered preventative service under the Medi-Cal program. Relatedly, the task force recommends funding pipelines for African Americans, especially those who are descendants of an individual enslaved in the United States who are interested in becoming doulas. This support should include full funding for credentialing. The task force also recommends fully funding care provided by doulas and midwives from conception to postpartum for African Americans, including free lactation education and education at every stage of pregnancy. The task force further recommends the California Department of Public Health's Office of Health Equity or other appropriate entity conduct an annual review of California healthcare laws and policies, including the Medi-Cal expansion related to improving health outcomes for the birthing population, including access to prenatal care. The review should evaluate the effects of these laws and policies on reducing health disparities among African American birthing populations and infants in California, and the findings and recommendations should be published to the California State Legislature. This measure would include funding on an annual basis to hire permanent staff dedicated to these efforts based on the Office of Health Equity's assessment of the level of staffing needed. The task force also recommends funding the Office of Health Equity to study all of the factors and causes that contribute to disparities in maternal and infant health outcomes among African Americans, including medical complications in pregnancy and childbirth, but also causes such as homicide and car accidents, and publish a report of findings and recommendations to the California State Legislature. This study shall include recommendations on how the state can remedy these disparities. Finally, the task force recommends state funding to the California Department of Public Health to evaluate the effectiveness of the Black Infant Health Program in reducing the health disparities and mortality rates among African American infants, and publish its findings and recommendations to the California State Legislature. These findings and recommendations shall include recommendations on a permanent source of funding for this program. recommendations on how the state can expand the program, and evidence-based recommendations on how the state can further care for all African American infants and work toward reducing health disparities and mortality rates. That was a lot. And we are going to pause there and we are going to conclude our reading of chapter 29. And we're going to stop at the bottom of page 795 and pick up again at the top of page 796. And this was Policies Addressing Mental and Physical Harm and Neglect from chapter 29. That concludes tonight's reading of chapter 29 of the California Reparations Task Force's final report. Before you go, if you haven't done so already, don't forget to like this video, hit the bell for reminders, subscribe to our YouTube channel. When you go, don't forget to get connected. Follow CJAC on all social media, Instagram, TikTok, Facebook, Twitter at CJEC Official. Get informed. Visit www.cjec-official.org and sign up for current and accurate California reparations news and info on our Get Involved page. Get involved, support our work by volunteering and/or donating. To donate, just click the Donate tab on the homepage of our website. Special thanks to our amazing fiscal sponsor, the California Black Women's Health Project. Thank you all so much for your time. I appreciate you. We are closer to reparations than we have ever been in the state of California. Have a great evening. Thank you so much and good night.